Good morning, everybody, and welcome to this morning's Festival of Governance event where we look at the primary care estate, an absolutely fundamental part of any transformation of the NHS over the coming few years. I don't know if you're listening to the Today programme on Monday, but in consequence of the NHS famous NHS England letter, which talked about more face-to-face contacts, there was a brilliant interview with Professor Martin Marshall from the Royal College of General Practitioners, and he was highlighting the subtle interrelationship between delivering potentials of integrated care, the new digital agenda that has been accelerated through the COVID period, and the very real need to have community purpose-built premises that could deliver good quality primary and community care. And that's what we're talking about today. 2/5 of our primary care estate is over 35 years old and 3/5 over 25 years old. We've seen how stretched services have been over the last few months, and we've got to live with social distancing and finding different ways of delivering care, at least over the next 18 months. The longer term context is the Naylor Review highlighting the significance of the primary care estate and how that reflects with the wider NHS estate. We've really always thought this an important factor, and we've been working with Primary Healthcare Properties, the market leader in primary care estate, over 2 or 3 years now. We've developed a report which was published a couple of years ago, and this week we're launching another important report which is looking very much at different ways of delivering a purpose-built modern primary care estate, and quickly too. They have a particular way of doing this called 3PD, which we'll learn about this morning. But we have a pretty thorough agenda. We've got a case study from my near town of Eastbourne of the development of a particular primary care centre, and we also have a wider look at how this fits in with the development of broader primary care services over the coming years. So without any more ado, can I introduce you to Harry Hyman, who's going to say a little bit about Primary Healthcare Properties and their work. He is the Chief Executive. Harry.
Thank you, Andrew. It's a great pleasure to see so many people logged on this morning, and let's hope this is a very informative debate. Primary Health Properties is a company that in fact I set up. We came to the AIM market in 1996, and we've been going since that time. We now have some £2.5 billion worth of primary care property. 490 of our 510 properties are in the UK. The balance are in Ireland, Republic of Ireland. We have about 600,000 square meters, which is in old speak about 6 million square feet, providing a base for 1,200 tenants. And we cater for 1 in 12 of the population who are registered at one of our primary care centres. Our whole acquisition philosophy is designed around providing modern, purpose-built, flexible, larger medical centres, and where necessary, investing in our existing portfolio to bring them up to the current day requirements. We're going to hear a little bit about the conflicting demands on space from Arvind Madden a bit later on. But we believe that, as Andrew was saying, that in the new world that we live in moving forward, there will still be a very large requirement for purpose-built large medical centres in order to accommodate the growing demands of vaccination, both for flu and hopefully in the future for COVID, the requirement for increased space through social distancing, and to encompass much of the long-term plans agenda of moving services out of expensive and inflexible hospitals into the primary care arena. We have more than 50 people dedicated to running the business, which is listed on the London Stock Exchange and in fact is in the FTSE 250. And our market capitalisation is over £2 billion. We have a lot of experience We're not in any way trying to get involved in the delivery of medical services. Our role is simply to be the facilitator of the development of new and the investment in existing buildings. And later on, you'll be sent some hard copy slides which show illustrations of our work across the country. We know that there's a massive opportunity for delivering more localized services to the patient. It always strikes me as rather ridiculous that some people cannot have a blood test in their own medical center, let alone anything slightly more complicated. We stand armed in order to provide what we estimate is the £3 to £5 billion worth of capital that is required to upgrade primary care across the UK. And we put a lot of effort in the last 12 months or so in trying to get the building debate in primary care further up the government's agenda. Of course, they've got lots of things on their plate, as we know, but I'm certain in my own mind that the future of primary care will be more robust with a modern primary care estate. So I welcome you all to today's debate. Thank you very much for attending. I hope you get the opportunity of reading the GGI report, which I think is very informative. And I hand back to Andrew. Andrew, over to you.
Thank you very much, Harry. It's been good working with PHP over the last couple of years. So without any more ado, Arvind Madan is probably someone who is known to everybody in primary care. He was a former National Deputy Medical Director and Director of Care of NHS England, and is a GP partner in the Hurley Group, and will take us through some of the bigger picture stuff. Arvind.
Good morning, everyone, and it's a pleasure to be with you this morning. The Chinese proverb, I believe, goes something along the lines of "May you live in interesting times," and I think we can all qualify for that at the moment. And there are multiple changes happening simultaneously, making the future quite hard to predict, much less the future of primary care estate specifically. But nonetheless, I'm going to have a go. It's clearly a tricky time for leaders to lead. But we do have some fixed points in the system. We know that, for example, CCGs are aggregating and merging. We have ICSs forming. ICPs are arriving on the landscape. And possibly one of the more fundamental changes is the emergence of 1,250 primary care networks acting as service delivery units holistically for their populations alongside stakeholders as service delivery units of primary care, which is, I think, one of the more fundamental changes in the system. But nonetheless, we have competing tensions on the question of primary care estate, and some of those elements are suggesting we need more, and some are suggesting we need less. And of those that suggest we need more, there's the short-term impact of social distancing, the need for hot and cold sites, and the division of practice premises to allow patients to flow through them differently. We have the arrival over the next few years of 26,000 extra allied healthcare professionals in primary care. We have momentum behind the ologies, particularly the medical-based specialities coming out into the community, the emergence of diagnostics and the advances of near-patient testing alongside the horizontal integration of community services and the emphasis towards co-location of services and the building of larger multidisciplinary teams acting as a sort of social health and care mission for a particular geography, sometimes using the intelligence that is provided by population health management. So quite a complex picture. And we know that the long-term plan has significant ambitions for what primary care will deliver to the wider system. And in fairness to commissioners, there is a funding trajectory that somewhat recognises that, and it will be interesting to see the impact of the Investment and Impact Fund starting from October, which hopefully aligns some of the pay mechanisms and incentives in the system to hold more of the morbidity in the community rather than sending it up to our already bulging hospitals. But there are also a number of pressures that may suggest we need less primary care estate. For example, the greater uptake of remote care, which has been a fairly seismic shift in the system in how general practice is managing demand at the moment. We've seen reasonably good acceptance from the public and more importantly, to some degree, the profession, who are shifting away from some of that protectionism of the traditional 10-minute face-to-face model, and almost a complete reversal of moving from 85% of cases being managed face-to-face to 85% of cases being managed remotely. And we've also seen this culture of home working embedding in the system, and we're experiencing the art of the possible as we speak. And then there are continued advances in technological capabilities, and we're yet to see play out the impact of other areas such as artificial intelligence, machine learning, remote biometric capture, genomics, and targeting of drugs. So there's a number of different elements in play. From my own experience, in a previous life, I was co-founder of an online consultation platform called eConsult, which, to give you some flavor of how this shift in the system of care is happening in numerical terms, back in December last year, we had 11 million patients sending in about 10,000 e-consults a month. That's now increased to 28 million patients sending in near 1 million online consultations a month. And what's interesting is over 90% of those cases, which would have prior to now resulted in a face-to-face appointment, largely are being closed remotely through a mixture of messaging, telephone, and video interactions. So the world has moved towards this concept of total triage, and we must be careful not to leave anybody behind. And digital exclusion remains high in everyone's minds to address alongside this new paradigm. And so we've moved from patient-initiated appointments to patient-initiated contact online with their surgeries and a needs-based interaction decided on largely by the clinician. And if one was to be reductionist about what general practice does between prevention, acute care, and long-term condition care, that's now being carved up along new lines in regards to what can be delivered physically and what can be delivered virtually. And with a focus on what the NHS has constantly emphasized about the right person being seen by the right service first time, every time. And examples of how this will probably evolve are within my own organization. We aggregate all our online consultations to a single home-based multidisciplinary team. And we're starting to experiment with how we can route those cases to the right clinician type with the right level of acuity and priority attached using artificial intelligence. And also there's the emergence of a more proactive version of care for all those patients who have long-term conditions, who quite often were the same patients left off follow-up year after year once the target for a practice was hit. So some say we've already gone too far in terms of the adoption of online consultations and online remote management. I suspect there's, to some degree, it will settle, particularly after something more definitive in terms of a solution emerges, such as a vaccine. But there is something that is to be preserved within all of this, which is the special relationship between doctors and patients that gives that continuity, the ability to coordinate care over a long period and support those patients, their families, and their communities through their various hardships. So if I was to finish by giving one prediction of where we're going to end up, I think the level will plateau in terms of the online versus physical share of how care is delivered. But primary care in the future will do more and host more services in the community, and therefore I predict we'll possibly need fewer, but certainly more sophisticated, versatile premises that will have to respond to changing wider system capabilities. I'll now hand over to Mark, I believe is
Thank you very much.
Going to give us a real world example.
Yeah, we're now going to
Eastbourne.
We're now going down to Eastbourne, and we're going to hear Dr. Mark Gaffney, who's a general practitioner down there, about the developing, the sexy bit of this, of course, the developing premises that PHP has been working with him on.
Thank you. I've been asked to talk on the actual experience of estate transformation And really the journey for me started some years ago. I've been attempting to develop a new surgery over a number of years, but this journey took on a new urgency for me when I became senior partner. The driver was that it quickly became obvious that the practice was in terminal decline. And I estimated we had 6 months to a year before matters became critical unless we took immediate action. The problem was several partners had retired in quick succession and no doctors wanted to join a busy, under-doctored practice, and the few locums we had kept us going. Further partners then left because of the workload, meaning those that remained were becoming increasingly stressed, often working beyond midnight each day just to clear the decks for the next day's onslaught. Illness in remaining partners was increasing and the potential death spiral getting faster. So with 11,000 patients in 3 small terraced houses, we had the smallest metre squared per patient of any practice in this CCG or the next. And there was a choice. We either had to give up or design a strategy to recover. And there are a number of sayings that I regularly use, and one of my favorites is from Richard Rummelt, which is, a strategy is just a wish list without an action plan. So to create a strategic recovery plan, the first thing was to identify the problems and then create 3 proximate objectives, specific things that we could achieve in the near term. The first 2 to tackle the problems and the third to make us outstanding compared to the competition. So the first objective was workflow, and to tackle this we took on paramedics, pharmacists, trained document readers, and all to redirect the workload away from the overstretched partners. And this was just before PCNs and Rs funding. The second was estates, and I'm going to talk on that in more detail in a moment. And the third, to distinguish us, was to excel in IT. We have a very strong background in IT, so to take us beyond the other GP practices, we employed an IT engineer and chose this as our showcase. Other surgeries will have a different focus. And that brings me to the next phrase that I favour, and that is that the doers do. Now, many people like to talk rather than to do, but a project of this size absolutely needs someone who will drive it. With estates, you have to sell your ideas to patients, partners, other practices, CCG, NHSE, Borough Council, and many others. And to do this, you have to have a clear vision, to be focused on specific outcomes that others can immediately associate with. CCGs are risk averse, so you have to invest energy and show them that you're serious and worthy of their attention. They will help and support you, but they won't do it for you. So a vision and an action plan. The next challenge was to decide whether to manage the finances ourselves and own the project or go with a development company. If owned, it'll be profitable in the distant future, but the risks and challenges are exponentially higher. To go it alone, you're mixing a lack of time with a lack of experience, a potentially disastrous combination. So my partners were not comfortable with those risks, and the much safer and preferred option was to work with developers. We invited an adjacent practice with similar problems to join us, both to drive economies of scale, but also to be a more viable and exciting prospect for the CCG and NHSE. Later, the CCG asked us to accept a third practice that had notified them they were handing the keys back in and resigning their contract that weekend. We're also absorbing the registered patients from the walk-in centre, that is depending on the public consultation, and that'll make the list size in the new building 27,000 patients. Size is important. We must not forget that we're planning for the next 30 years. Replacing a small building with another, newer, small building is pointless. We had a clear plan for redesigning GP services, for moving away from the failed hourglass model. We've employed allied health practitioners, have included AQP, NHS secondary care, have 2 operating rooms and plan outpatient hysteroscopies and cystoscopies, all in-house, all to improve the patient's journey and to take the pressure off the hospitals. The GPs will continue to diagnose, initialise treatment, monitor and refer patients as before, but we'll have teams of allied health professionals running subspecialty and multimorbidity clinics under their guidance. So rolling clinics throughout the day, direct access to consultants for specialist advice, training hub, facilities, and much more. With design, we had to think about the patients. Simple things such as how far can an elderly person with comorbidities walk within the building? And even the doctors in a building for 30,000 patients, one could easily never see one another. So in addition to the consulting rooms, we opted for a large doctor's administration office with individual workstations to ensure peer support and communication. The developers will research what is available locally, produce architect drawings, time schedules, apply for planning, purchase a site, talk to the CCG, the council, the district area, employ contractors, and much more. On top of this, you need to employ solicitors, monitoring surveyor, and a merger company, and all of these cost money, much more than is provided by the CCG. But GPs have to be prepared to look to the future and manage expenses and not fret about them. They're inevitable, and we're investing now for the next 30 years. So finally, my third phrase, paraphrased from a 1989 film, which I said to the partners at the beginning, is if you build it, they will come. We've taken on 4 new partners in the last 6 months, 2 of those in the last week, new paramedics and pharmacists, nurse associates, physiotherapists, also supported by ours funding. We've set up a board of directors, employed a CEO, a business manager, and 4 departmental heads, and we have some 70 staff. So the change is palpable, it's almost unbelievable. And people are now contacting us, asking to join the vision. So I'm happy to answer any specific questions about it, but remember, a strategy is just a wish list without an action plan. The doers do, and if you build it, they will come. Thank you.
Thanks ever so much, Mark. It's always great to hear about that. While people are forming their questions or contributions, and you might have seen in the chat, I put them there first because I can't see you all. Let's, we've got a half an hour, a bit more than half an hour to go through this. Now, you mentioned the value of the new centre in attracting staff, build and they will come. How direct was it with the partner recruitment particularly?
Oh, it was utterly disastrous at the beginning. We had no one wanted to join. We tried the agencies, we tried advertising, we tried everything, and we just couldn't persuade. People would come, they'd look at the buildings that we were in and walk away. And it was a death spiral, to be honest. I use that phrase in the talk. The reality is now people are coming to us and wanting to join, and that's a total transformation.
Okay, so I've got a question here from Sonia. Sonia Ashraf, do you want to introduce yourself, Sonia, and ask your question?
Yeah. Hi, I'm a GP in Birmingham. We also have a population size of 27,000. And what I found very interesting is how you managed to get cystoscopy and hysteroscopy. So it's just, how did you involve secondary care?
Right, this goes back a little way into my history. I set up an AQP provider company quite a few years ago. I stopped being part of that when I wanted to take on this project and to move this forward. So I didn't want the conflict of interest. But as an AQP provider, and I ran it for 8 years, we employed some 20, maybe up to 30 consultants, urologists for cystoscopies, for instance, colorectal surgeons, general surgeons, ophthalmologists, ENT, you name it. And we actually provided secondary care with the support of the hospital. We went to the hospital originally and said to them, you're putting all these referrals into a box, you're not coping, we can help, we can do it out in the community. And the hardest part of that was getting the licensing to do it properly. But once done, and with all the consultants, that company is still going. So we've just approached them and said, come and join us in the new building. I'm not a part of it anymore, but that's still live and working. And anyone can do that, but even as GPs, you can invite consultants in to work with you in general practice surgeries.
I've got a lot of questions coming through, some privately to me and some to everybody. It would be interesting to get a totally different perspective now from Jeff Buggle. Jeff, do you want to ask your question?
Yeah, yes, thank you, Andrew.
And introduce yourself.
Sorry, my name is Jeff Buggle. I'm the Regional Director of Finance for the East of England. Mark, so thank you very much for that, and it's really interesting. Who advised you as to the best way forward? Because I suspect that the dilemmas and the debates you had with your partners isn't your field of expertise. So where did you seek advice, and what were the other options they talked you through?
Right, you're actually much on your own. There isn't a lot that comes from elsewhere. We talked to, yeah, probably the first thing that I did is I got all the partners together and we went over to a surgery that had been built down along the coast in Newhaven. This was actually owned by the partners and built themselves. And we, because I knew the senior partner there very well, he was very honest, told us all the costs, all the pitfalls, everything that they'd learned and experienced. So we went, by going to someone else who'd done it, we then got the feel of what it was really like. From there, we had the decision, do we take the risk, get the bank loans, do it ourselves, knowing that we've got no experience of building a building of any size, let alone this size, or do we go and approach the developers? And it's a bit of a no-brainer. Taking on that risk, I mean, one of my partners said to me, I'd rather sleep at night than worry about the money. It was as simple as that. So it was a no-brainer.
Harry, you messaged me with a relevant question. Harry Hyman.
Yeah. So just picking up on a couple of points now that the conversation has moved forward. My experience of talking to partners in pretty much every new building that we have acquired or procured the development of, working with the GP practice during that period, has been that without a doubt they find it much easier to recruit partners to their practice, because it takes away the requirement to put in equity. It means that the issues of dealing with a property owning partnership where members change over time become removed. And because of the unique position of primary care enjoying a rent reimbursement, it means that there's very little exposure for the doctors themselves in paying the rent, because that's paid by NHS England through the CCGs. To pick up on Mark's point as well, the way that we approach new projects is to work with the practice and, if necessary, a third-party developer, although sometimes we do this ourselves, and building up a business plan which does examine the options and which is used to convince the CCG that this is the best way forward. And an important component of that, nearly always, is the service delivery benefits that will flow from the new centre, because clearly the new centres will, as a matter which is pretty much obvious, you know, a big new £8 million medical centre that Mark's moving into in a few months' time is going to cost the NHS more in rent, because it will cost more than the 3 or 4 properties that it's replacing. But it's not an apples and apples comparison, because you're looking at a very large building compared to some very small, not fit for purpose properties that Dr. Gaffney and his colleagues in the other practices were practicing out of. And that can all be put forward in a business case before the process gets too far down the line. And that buy-in has to happen really before the project becomes a runner, because the CCG has to agree that the rent will be reimbursed, and obviously the district valuer has to be involved in that process. But my colleagues Tony Coke and Chris Santa are well versed in that, and that's something that we can help the practices with. And that would include talking to the CCG about which secondary care or less intense procedures can be located at the medical centre. You know, Dr. Madden talked about the ologies, minor procedures, diagnostics, increasingly starting with blood tests but moving up into X-rays, can all be. Why can they not be co-located in a hub medical centre?
Okay, that's good. I've got some various other questions around, and you know, you can ask questions not just of the speakers, by the way. So there's one here from Andrew Hughes, who had a role in it was a GP federation, wasn't it, up in Stafford, as well as being an NHS director, as well as being a senior member of staff until early this year at GGI, as well as running a number of charities related to medicine. So, Andrew, you have a slightly waspish question, I see.
Waspish, crikey. Thank you very much. It follows, I think, naturally from what Harry was just saying previously, actually, which is that from experience, one of the biggest issues is that for many, particularly equity partners, quite understandably, the estate from which they operate is part of their pension pot.
Yeah.
So when it comes to developing business plans, does PHP assume that those partners are contributing that equity, or is it something that's bought from them?
I think
how is that managed financially?
It depends on the circumstances, but very often the developer or us in connection with the developer will come up with a plan for either realizing the value in the existing property or disposing of it as part of the financial appraisal of the development. And you're quite right that historically many GPs have seen property ownership as a route to their pension security. But in today's day and age, that doesn't necessarily follow. And although I'm not allowed to give financial advice, you know, you're probably better off with a bit of a spread of assets, some in bonds, some in equity, some in property. And that disposal of the property and also dealing with the fixed rate debt that may or may not be left on the property is a very important part of the plan and can give rise to some delays. But essentially, the GPs should look to the developer to sort that out as part of the proposal.
Okay. I'm going to ask Roisin. I've got loads more questions, so we could carry on, but I think it'd be quite interesting. And this is the sort of thing that gives me the heebie-jeebies, but I'm going to ask Roisin from GGI. We've got a very simple poll and it will just pop up on the screen. And my understanding, unless Roisin tells me otherwise, we can carry on chatting while it's being done. And there we go. It's just a quick poll about what's in your sort of local area. And while you're filling that in, I was going to then ask Liz Anjay, I'm sure I've got that wrong. You had a question. You'd missed the beginning of the webinar, but you wanted to ask something which was not unconnected really to some of the other points being made. Do you want to introduce yourself, Liz?
Yeah, thanks. It's Liz Anjay. It's French, but you nearly got it right. Yeah, so I'm a clinical director of primary care, West Hants, so I'm portfolio GP. So I guess my question was, and I'm sorry I joined late, was I've worked in many locum positions and you often find yourself in the sort of the back room with no facilities. So I think sort of locums would be interested in this type of estate because they go into it. Many people actually are interested in a portfolio career rather than partnerships, and some of the language around is in partnerships here, and I wondered how that lands. And also, I guess, are you employing GP with extended roles because they could do their own clinics? And how are you looking after shielded staff? Because I think it's suddenly got a lot busier. There isn't quite the room for people to work, but there's lots of ways of working, particularly with extended waiting times now and providers in the community. If you could sort of do mixed working with a bit of remote, a bit of extended, and also that you utilise your workforce in a way that feels welcome, everyone coming to the building.
It'd be good to get Arvind in as well on this, but do you want to start off, Mark?
Yes, absolutely. So shielded staff first, because that's the last thing you said. We've got 3, I think, shielded staff. Obviously, shielding is not there now, but what we did was 1, we kept out of the building and just worked remotely. 1, we isolated within the building, and obviously the bigger the building, the better for that. And prevent them from seeing actual patients, because that's the thing where the real risk was. Like all the surgeries in our area, all the staff wear face masks and PPE, and the doctors PPE and so on for seeing patients, but we also have a hot hub. Now, what was the first part you want to ask? Portfolio GPs or partners? We're all partners, actually. Partners seem to be coming back to the frame. There's an incentive at the moment, so our 2 new partners will get a nice little golden handshake for becoming partners. That's nothing to do with the practice, that's what's going through. But no, they've all joined in. I prefer partners because I like everybody to have an equal say and to have an equal vote, rather than salaried doctors. We have had salaried doctors, but the difference between a partner and a salaried doctor is who stays behind and does the extra bit when it's necessary, and when people are off sick. So that's been our experience of it. So I'm in favour of partners. Partners are coming back.
Arvind? So do you want to come directly to that, Liz, and then maybe Arvind?
Yeah, I think that's one view, that partners is where everybody's going. I'm sorry, I don't agree with you. Many people are portfolio and salaried, and they also stay behind time. So let's not work with that narrative, please. But
okay, one of our partners who started as a salaried partner has moved to being a full partner. They wanted to, as a salaried, into partnership. But it is horses for courses. It's whatever works for the individual.
It's a sort of interesting thing. The Wolverhampton model, where the NHS Trust has intervened in primary care and runs, I think, about half the primary care list for the city of Wolverhampton. They rather would agree with Liz, and when asked why they feel they've been successful in doing this, and they've got some spectacular results. They would say it's all to do with employment and premises. So Arvind, have you got a perspective on this?
Yeah, so I guess part of the sentiment behind the primary care network movement, if you like, is to actually enrich the primary care offer and create that left shift of services towards primary care alongside the resources. And in my experience, too often, the estate strategy has been contaminated by general practice ownership considerations. And therefore, actually, what's best for that population may be somewhat sabotaged by the fact that it wasn't aligned to the interests of a GP or group of GPs owning a building that was never going to be capable of delivering that range of services. And that's, I guess, to some cases, when neither has a vested interest in the building and their main focus is on the richness of the service offered to patients. So I would say that actually, if we can make estate strategies across primary care networks that make sense for the population as their primary interest, rather
Arvind, you're difficult to hear. You're difficult to hear because you're moving backwards and forwards.
Apologies, I'll stay forwards.
Yes.
So my overall point would be that actually we need to make service delivery agnostic of who owns a building, and too often at the moment it is not.
That's a good point. Okay, could we have a quick look at the a couple more questions? We're going to come to Simon and to Joe, probably in the reverse order. Rasheen, have you got the results of the poll? Gosh, isn't that interesting? Isn't that interesting? If anybody's got any sort of remarks on that, again, put them in the chat and we can put the poll up there. Gosh, that is interesting. Okay, thank you very much for that. Joe, I was going to come for you first. It connects with what I was saying at the beginning. Do you want to introduce yourself, Joe McGilligan?
Yeah, I'm Joe McGilligan. I'm a senior partner in Red Hill in Surrey, and also a board member of Surrey Heartland CCG. It's nice to see you all again. One of the things that we're trying to struggle with is the total triage of patients, doing it digitally or either email or video consultations, with the assertion from the NHS England that says we should be offering patients face-to-face appointments. And the thing is, we've had a lot of our partners and our salary doctors working from home over the last 6 months, doing telephone and video consultations, and only very occasionally bringing patients in to be seen. So it is, we've been moving towards a model like Babylon and, with AI and all of that, and yet we've been told to look at estates and see patients face to face.
Arvind,
if I go first, yes, at the moment we're 17.5% face-to-face in terms of consultations. It doesn't mean that we've stopped working or seeing people. I was looking at our numbers. In July, we had the receptionist went into a patient's file 24,500 times. This is on 11,000 patients, the current list. GPs opened the file 13,500 times, so went in and dealt with the patient, and that's just in 23 working days in July. So we're still fully functional, still fully operational. What I've discovered, and I think all of my colleagues have, is we didn't need to bring everybody down in the first place. An awful lot of things just need sorting out. Video has been fantastic. You can see a lot. Skin lesions, we have close-up photos coming in with the link that comes so we can see every skin lesion. And those are automatically, if necessary, referred on to the dermatologist and sorted out. So I am sure we'll be doing more face-to-face, and as was said before, a balance point will be reached. But the reality is, this is actually a better way of delivering the service. We were struggling beforehand, now we're not. And we can see more patients, and we do more consultations in a day than we used to do. purely because we've got more time. We're not waiting for someone to come in the room and take their coat off, as it were.
Can I ask Arvind also for a response, but can I put in a supplemental to him? So, I mean, if you could broaden out the discussion against the unfolding desire to make integrated care more real through ICSs as well. So the particular point that Joe originally made, and maybe broaden it out a bit.
Is that to Arvind?
So I think I think we're going to see an increasing list of capabilities of what is possible remotely. So, for example, we're working at the moment on how do you capture pulse, blood pressure, respiratory rate, oxygen saturation, and temperature remotely from a patient. So, for example, they can start their urgent care journey from home. And make a more discerning decision over whether they need to go to an accident and emergency. And equally, the clinicians can make a more discerning journey over what modality to interact with that patient. And I think Mark's right in terms of this will find its own settling point. And I go back to the other element that is yet to play out in the system, which is the fact that we will start to be able to capture output of particular interactions that allow us to feed the machine learning that will allow us to start routing in a more sophisticated manner the right case to the right clinician first time every time. And that, in terms of broadening it out, will include the wide variety of disciplines that sit within the primary care network multidisciplinary team. So I don't see it being a very long time before patients with inbound communications that are captured electronically, and I recognize that's not for everybody, but I think there are other things in that space that are happening, for example, voice user interfaces, will be able to make smart decisions about what type of interaction that patient may need. But within that, we must try and maintain an element of patient choice. And there is currently an arm wrestle happening between the profession and perhaps the politicians as regards whether the threshold for where that entry point is set is in accordance to a desired appointment on the part of a patient or a required appointment from the perspective of a clinician. Some would argue that the system's only paying for what's required and needed by patients for other reasons. And that's something we can see playing out, for example, in a Telegraph headline earlier this week.
Okay, thanks for that. You're still coming and going a bit. I was going to ask. I was going to get Simon Wilkinson to make his quite specific point, and perhaps Chris Santa could answer that from PHP. But I was then, hopefully we can sort of broaden the discussion out a bit. And then I was going to ask you, Harry, if you might talk about some of the, or an example of some of the bigger centres you run, because of course, that's again somewhat interesting in how you specialise. I think that might sort of, unearth some more questions and points. So Simon, you had a particular question, and I think Chris Santa can answer that. Simon Wilkinson, do you want to introduce yourself?
Yeah, good morning. Thank you, Andrew. Apologies for not putting the camera on. I tend to have connection issues whenever I do, so hopefully I'm coming through okay verbally. If I may, I had sort of a couple of questions. One was, and thank you, Harry. I think you've put an answer, part answer to the question. One was just
your job as well.
Sorry, beg your pardon. Simon Wilkinson. I'm a commissioning manager for primary care at North Hampshire CCG. So sort of coming from this, obviously from the commissioner viewpoint. I say 2 points really. One was just around obviously the rental side, and obviously that's for general practice. One concern to them is always around the current market rent valued from the district valuer, which obviously is what us as commissioners reimburse against the actual rent, and obviously wherever possible, so we want to make that cost neutral to the tenant, to the GP practice. And I suppose it's just really from PHP's point of view around, again, generally, do you accept the DV's valuation, or again, obviously, you would obviously get your own valuation advice, and generally is that in line with the DB to make it cost neutral for the practice? That's sort of one thing. The second sort of question was, obviously in the current climate, we're looking to do across commissioners at the moment is, again, obviously gearing up for a potential very challenging winter. Obviously we could see a second, third spike, obviously with COVID. We're looking, obviously, models that we had obviously back earlier in the year around the sort of the hot and cold sites. And one of the models we're looking at the moment is maybe having obviously dedicated hot sites.
Yep.
And it's just, I suppose, getting a view from PHP around how you would feel maybe configuring one of your buildings, maybe temporary, using for one of these sites, and if that's something you'll be happy to work with the commissioners and tenants around.
Yeah. Well, we were. Chris, do you want to deal with the second part, and I'll circle back and deal with the first bit?
Sure, certainly. So Simon, thank you very much for your question. Yes, we will work with commissioners and tenants to help them adapt their premises to deal with the current challenges of COVID-19. We have done this already. Where requested in the portfolio, we've had a number of requests from our tenants who've come forward and asked to help adapt things, whether it's triage areas in car parks, whether it's separate entrances, whether it's dealing with the flow of patients through centres. We have a number of centres in the portfolio that were designated hot practices, and we've supported the practices wherever we can there in making those changes. So absolutely, we understand the short-term needs of the system, and I think as a general point, what we found is the buildings that have been more modern, purpose-built buildings are more flexible and have been able to deal with these challenges and these surge issues more flexibly than older converted buildings. I'll pass back to Harry then, just to discuss the point around the rental as well, and the rental reimbursement.
And the larger centres when you're done with that.
Yeah, sure. So thanks very much, Simon, for your question. We do accept the current market rent valuation for the new property. There's a couple of sort of ambiguities in your question. I think, as I alluded to earlier, the existing rent valuations on the existing properties are not the cost envelope for the new properties, and how you bridge that difference is down to the service delivery benefits and the bringing together of practices, consolidation, efficiencies, and improvements in the patient experience. But when you say, do we accept it? We don't accept what the DV says first, because this is a negotiated position. And because we have 1,200 tenancies across the NHS, we don't have as much data as the district valuer, but we do have all the up-to-date data. And although the district valuer is supposed to set an open market value, right? Undoubtedly, and these are my words and I'm going to choose them quite carefully, they see themselves a bit as the guardian of the public purse, and getting an appropriate valuation for the rent per square metre is an art form rather than a science, and it takes quite some time. So, you know, the difference between £190 a metre and £210 a metre, superficially doesn't sound a lot, but it can make the difference between a scheme proceeding or not proceeding. So it's a negotiated position, and we're very happy with our developer partners to do that discussion on behalf of the GPs. And so the answer is that not in every case, because sometimes the GPs want to pay for extra space for elements of their own private interest, and sometimes GPs want to install things like air conditioning, which is not part of the GMS reimbursement currently, and other improvements. But I'd say like 98% of the time, the passing rent on the GP surgery is in fact the district valuer's agreed rent, and there's no exposure at rent review either, because rent review, our lease is structured so that it stays at that. It stays at the DV level, whatever that may be moving forward. So to pick up on Andrew's point, I just pick you up on one thing, Andrew. We don't run the centres.
Sorry, of course, yes.
No, the GPs run them, or the foundation trust, or modality, or whichever federation or Vanguard is running the property, runs them operationally. We can be involved in dealing with planned maintenance on the exterior of the building, but everything inside the building is down to the local healthcare providers. So we're not setting ourselves out as the experts in how to run primary care, but some of our centres are pretty much close to cottage hospitals, really, in the way that they are analysed, and obviously we've got details of the Eastbourne Primary Care Centre, which will be in the material that gets emailed round to people at the end. We're also doing another new building in Llanbradach in Wales, and some of our centres, like for example the St Catherine's one in the Wirral, is a £24 million building, which is substantially a community hospital with all the and you know, out of the space there are 3 wings in the building, and the GPs only occupy 1 wing, and the other wing is run by the local trust, and effectively delivers non-urgent, non-critical care to the same population base as the GPs are serving. And I guess in the fullness of time, from my perspective, you know, maybe that will come together in an integrated care system, primary care network, so that the whole thing is around core and spoke type models. So, you know, our largest building is knocking on for £30 million. The average lot size, as a rough proxy, is a £5 million medical centre, and Dr. Gaffney's centre is coming in at £8.5 million. Interestingly, just by way of comparison, because I think it's quite interesting, the Irish system, which is obviously completely different in terms of structure, but because of their geography, they've embarked on building 200 new primary care centres across Ireland. Because there was never any rent reimbursement in Ireland, in very shorthand terms, there's been no investment by GPs in primary care there. And the HSE, the Irish equivalent of the NHS, is setting these centres up with about 65% of the space occupied by them, and about a third, the remaining third, occupied by pharmacy and GPs. Very interesting, and those centres have out-of-hours services, defibrillation, certainly X-ray pretty much in every one of them, so enabling the local population to avoid large journeys. So we have a centre in Mallow, which I've had the pleasure of going to about 5 times, and it's an hour and a half, well, probably an hour northeast of Cork, and 2.5 hours southwest of Dublin, so very rural. And I asked one of the doctors there what happened if there was a road traffic accident, somebody needed, you know, urgent attention. Well, it's an air ambulance, which is, you know, very, very expensive, and you know, even as a layman, you can see there's pretty, who knows. So having defibrillators, out-of-hours services, X-ray machines actually in Mallow makes one heck of a difference to the population. In the same way, you know, as patients now are not just allowed to pole up an A&E, they're being redirected, aren't they, into the primary care and walking centres. So that's, I would say, as a patient, unless it's something enormously critical, that's a better way to go, and it's more convenient and more cost effective. Like Lakeside's ambulatory care centre in Corby, which I've been round, which has a 2-hour wait. You can have your bloods tested there, much easier to access for the population, and relieves the pressure on the local Corby hospital.
Okay, I'm going to bring things to a close now, as we're coming to the end of it. We have a question from Andrew Hughes, and maybe in your wind up, Harry, you might mention that. So anything that you'd wished you'd been able to say, and if we could start off with Mark and then Arvind and then Harry. But before that, Jessica, do you want to very quickly just tell everybody about the report? I know it's been circulated, hasn't it?
Yes, hi everyone. Thank you for a really interesting discussion. So you should have received the report yesterday evening. It's also going to be uploaded on our website and the PHP website, I assume today. It should be going up imminently. It's covering lots of the conversation that we've had today, looking at the challenges that are faced by primary care estate at the moment, and GPs, how COVID affects this situation, and what the opportunities are for primary care estate in the future, including examples from PHP amongst others. So we'll make sure that you have that along with Harry Hyman's slides that you saw earlier, which should give you a bit more background information. So thank you very much.
Okay, thank you, Jessica. Jessica is one of the team at GGI. She's our digital development manager. And before we just go 1 minute each to Arvind, Mark and Harry, can I thank you all very much for taking part in the Festival of Governance. The festival goes on until the end of the month. You might particularly like Monday's webinar, which we're doing jointly with the Cleveland Clinic, which is about physician-led organizations, 10 o'clock in the morning. And the 22nd, our annual lecture, which is normally with lovely glasses of champagne and things, we're giving Dame Janet Smith, who has a special part in the history of primary care, when you think about it. We're getting Janet Smith is getting the Good Governance Award, and Rob Whiteman, who's the Chief Exec of CIPFA, will be giving our annual lecture, and it will basically be on the politicisation of the civil service. So that'll be an interesting one. No controversy there. But as I said, thanks for taking part in the GGI Festival of Governance. So let's just wrap up today's interesting session. Do you want to go first, Arvind, then Mark, and then Harry? 1 minute each. No hesitation, repetition, or deviation.
Can you hear me okay? Okay, so I guess one of the mental pictures I carry around in my mind when I'm thinking about service design is actually the sort of 4 doors into the system. 450 million patients per annum attending their community pharmacy, 300 million plus going to their GP surgery, 100 million outpatient appointments, and 26 million urgent care attendances. And I think the convulsion in healthcare design caused by COVID is going to disrupt each of those doorways in a way that is potentially positive for how we short circuit millions of traditional patient journeys into their GP practice or up to the hospital or into urgent care in the way that Harry suggested. A sort of one-on-one first, for example, is one element of that, in a way that is quite hard to predict at the current time. And what the net balance effect will be on the requirement for primary care estate, as I mentioned earlier, is hard to predict. But my guess would be that we're going to, as I said, need fewer polyclinic-esque type facilities that will offer a far richer range of services that are more targeted based on the data analytics and population health management insights that we gain about what is a viable service in a community with all the horizontal and vertical integration that involves. And it will be a sort of reset opportunity. Whether we take it or not is a different question, but a reset opportunity for how we flow patients with their illnesses through the system, which I think is particularly exciting. And I think primary care estate can play a major role in that.
So, Sonia, we haven't got time to answer your question. Do you mind if I connect you to Arvind so that it can be answered? Sonia in Birmingham. I think you're on the governing body in Birmingham. Yeah. Okay, we'll do that. We'll connect you. Okay, Mark, you've got just under a minute.
I'd actually say that having a new building or being part of a new building being built has transformed the way that we're doing the medication, the way we're sorting out, looking after patients, all the things that we can now do that we could never do in the past because we just were hot desking and didn't have space. It's also brought several surgeries together, and that helps enormously with stability, having more partners, we can cover illness and things like that. The journey has been painless. It's been absolutely incredible. We've gone from nothing to almost having the new building completed. I mean, it's going to be another few months yet, but we can see where we're going. But all of that stress and angst and difficulty has been taken away from us. We're just getting the end part, and for that I'm very grateful. So a lot of people have come into play, the CCG in particular for supporting it, PHP for building it and doing it, but it's made a huge difference. And having the new building is the difference for us between life and death of the surgery.
That's nice positive note. Harry, you've got less than a minute.
I don't really need a minute. We stand armed and primed, ready to help the NHS with this incredibly important agenda of modernising the primary care estate. One point that I didn't bring out was that we want to do this in an environmentally acceptable way with lowering the carbon footprint, helping with the NHS's journey on that direction. And we have more than 400
Now, at a crucial
million
point,
pounds available right now. Very happy to speak about that.
So Harry
That's
cut
my
out
minute.
when he said he cut out at the moment where he said he's got 2 billion quid in his wallet to.
I said 400 million before there's any doubt about that.
Okay, right. Okay,
Still enough for a lot of medical.
Enough to really address those figures and what we heard about Brittany. Look, thanks ever so much. I hope we see you again. Bye bye.